these are dancing choroids. Okay.
Yeah,
No.
dancing choroids. So we'll have Gopal for a change. Gopal is the king of
This
choroids.
is an intraoperative choroidal detachment, which is seen in a normal vitrectomy. I made an opening about a sclerotomy about 5 to 6 millimeters behind and used the active suction of the green tip, went into the suprachoroidal space, and you can now see the green tip there. And slowly you can see that with the active suction, that is, the choroidal detachment is completely drained. So this is a technique in which we can go through the, if there's a choroidal detachment there, because of some reason. Yeah, so here is the choroidal detachment because of some misdirection of the cannula. So what I did was I made a sclerotomy posterior to it, went into that, and actually you can indent the choroid there and you can see it through the microscope and then completely take it and move out. So that's the technique which I just showed.
So very nice technique. We'll start with Hemant first and then Pramod. Have you done this technique, or none of us wants choroidals, but what do you, any comments on this technique? Very nice.
Yeah, very nice, elegant technique, Gopal. But I would, I have done only I've just used a non-valve cannula to drain the choroidal fluid. I've done it passively. So primarily we use a passive mode, but I think he has shown an active suction on it.
Shobit?
Sorry, I missed this video. I had to.
Oh, that's okay. Manish, any comments?
I think he showed it very elegantly. I couldn't have done anything better. I think only thing I would like to ask him is that how does he decide the depth, or does he wait for the fluid to come in and aspirate, or just for the sake of safety, what do you think is the way you go in?
This was a case in which there was a fresh choroidal detachment, and we could see that the height of the choroidal detachment is maximum in one particular area. So right. The aspiration cannula is directed towards that area, and actually the intent of the aspiration cannula can be seen inside the retina. So when you are seeing that, so that when the choroid is egressing back, you are also slowly taking your aspiration cannula back. But as you can see in the next few videos, this type of technique I used again, and it failed miserably also. So I don't think this is a fairly reproducible technique or anything like that.
How does the soft tip negotiate the external entry?
The external entry is slightly difficult, but once you negotiate that external entry, there's a huge suprachoroidal space there, and this is fresh fluid, so it easily comes out. With blood or something other like that, it may be a little difficult.
So I think that was going to be my question to you, and for the audience to realize, you realize that this was a serous detachment, not a hemorrhagic detachment.
Correct.
So very important for the audience to know that this is not a way to suck blood. This is a way to suck fluid. So I think that you already made that decision and indication, knowing that, right? I think that's the key with the technique. You have to know, what are you sucking? Okay. Okay, if there's no other comments, then we move on. Anand?
Yes, please do. Yes, let's move on to the next one. Sai, can you share?
No, this is the one which is now shown. This is a retinal detachment in which we are almost finishing, and I'm just lasering the tear. You can see that air fluid exchange is done, and I just went out, changed an instrument and went inside. You can see that there is a lot of brownish color just behind the lens here, and when I go inside, I see nothing. Suddenly I see nothing, and I immediately understood that there should be, since there's a brownish color here, I understood that there's choroidal detachment. Immediately I looked at the infusion cannula, and we are under air now, and I saw that the infusion cannula has partially slipped out of position, and that has what has happened is, so I removed that and put it in another location. Probably I put it superiorly or some other location. Yeah, I did not want to change the fluid right now. So under air itself, I put it into another infusion cannula, and then went inside, and so I saw this particular choroidal detachment there, which is there. And I again tried because I know now it is air. It is not fluid, it is air, it is not blood. So air should, move up. So I make a little more, anterior sclerotomy because I know that air would come up, and try to go with a cannula there, partly going inside, so that I'm in the suprachoroidal space for the air to go out. I'm slowly withdrawing that cannula to see if air is coming out. I'm basically directing it in a way that the air should gush out, but nothing happened. And then this starts happening. So I have injured the choroid there, and then there is a bleed which is coming in. Now I am under air. Now I shift into fluid, and then try to remove the blood. More bleed is coming. The patient is also slightly hypertensive, and slowly and slowly, the surgery would have stopped about few few minutes ago, about 30 minutes ago. We had slowly cleared the blood, but I was not able to remove the choroidal detachment at that point of time. So I injected the silicone oil here with a choroidal detachment in there, and then I had left the patient. This patient had a little bit of inflammation post-operatively. You can see that there is this choroidal detachment, and the peripheral blood has stopped flowing. So I filled with silicone oil. Final visual acuity was somewhere around 6/36. Now the choroidal detachment is completely regressed. Usually the choroidal detachment like that may regress over 1 or 2 days, but this took about a month for the choroidal detachment to regress.
So very nice case. Pramod, the question for you, let's say you saw this, one option would have been just to leave the subretinal, leave the air, right? Because now
that's the biggest lesson.
Exactly, because lasers were well laser, everything is settled down, and you are so sure that it was only air. Yes, if you would have had little bit underfill, I agree with that.
Yeah.
But I think,
but it was a superior tear.
Yeah, and particularly break if it is a superior quadrant somewhere, I think you just leave it alone.
Just leave it.
I think this is another good example when to leave the dance, right? I think.
Can I comment?
Comment.
Yeah, I think the other part that we should also talk about is that at the end of surgery, when you came out and went back and you saw that, so this kind of a thing can happen. One is that the cannula has gone in that space, but it would not fill up like this unless there is hypotony in the vitreous cavity. So your cannulas outside have to be leaking or something, and so that combination of the infusion cannula going and the low pressure only can lead to such a thing. So if your pressure inside was fine, this would not happen. Even if it goes there, that air would only remain limited, or you would feel that no air is coming inside, but it would not cause a huge choroidal detachment.
I was using a non-valve cannula, and if I were to be using a valve cannula, probably this complication, the choroidal detachment may have been much lesser inside.
Absolutely, yeah.
I think Manish is exactly right. It's with air, oil, everything has to do with high pressure to low pressure, right? Vice versa. And the other thing to be careful about in this patient is, once you have air in the choroidal space, patients can get an air embolus, right? So they can die.
Exactly, yeah.
So you need to have the anesthesiologist be very careful in this. Look at the end tidal CO2. If that drops, you need to make sure, let them know that, and they need to be aware of this. But the common mistake people do when they have this is they raise the air pressure, making it even worse, right? Yeah. So very, very, so you can kill the eye and kill the patient. But Pramod has a question.
Yeah, the same comment. There are a couple of papers having, because of air directing in a suprachoroidal space, having a severe emphysema, face and chest, whole thing is balloon up with the air. There are a couple of cases. I just wanted to drive that point, and yes, air embolism is there.
19 cases who died actually.
Yeah.
Can I make a comment?
Yes, Dr.
Generally, the air embolism would come if you raise the pressure much higher. So as Gaurav had said, if you make it 50 or 60, because it has to go above the perfusion pressure of the eye, only then embolism will occur, so that it has to go through the vertex vein. So if you're keeping it at 25, 30, then generally it doesn't produce so much.
And that's why one of the things that people do, and I tend to do this all the time, is I start my air infusion passively with everything passive extrusion, and then I switch to active once I know air is in the eye. And I also let the anesthesiologist always know we're going to air. And again, not for straightforward cases, but retinal detachments that have had multiple surgeries and so on and so forth. So they watch the end tidal CO2. Very, very important to do that. So very nice case, Gopal. Again, as I said, it's very easy to comment on surgery on Monday than doing it on Friday. So all good points. Anand, we move on.
Yeah, we move on. Terrific case again.
Good evening, everybody. It is almost like same case like Dr. Gopal. A sudden intraoperative kissing choroidal. It was a case of rectvertiginous retinal detachment with hypotony. Initially, I corrected the hypotony by injecting BS saline injection inside the vitreous cavity to raise the IOP. Then introduced all the cannulas, checked the tip of the infusion cannula. It is intravitreal, okay, and then started doing vitrectomy here. And when I completed, after completion of vitrectomy, I injected PFCL to settle the RD, then started doing fluid exchange, vitreous base excision, then settled the retina and did the laser. I was almost on the verge of completion of my case. Just one step was left. It was injecting silicone oil. So when I removed my everything is right, like I removed my introduced the VFC syringe tip. Now the visibility was gone. Oh my God! The opposite retina is totally. It is just like Cushing choroidal. So what next to be done? My the case is almost I was about to finish the case. Now I examined all the cannulas, and I have seen that my infusion cannula, which was in the air infusion state, it is in the partially withdrawn stage. I was sure about the right-handed cannula, it is intravitreal. I put the infusion cannula. Now see the magic. The whole Cushing choroidal is gone. So now again I introduced one non-valved trocar cannula 25 gauge inside the through the pars plana inside the suprachoroidal space to remove the residual suprachoroidal air, and again introduce the regular infusion cannula in the original place, check its tip, and then remove PSCL, complete the case with the injection of silicone oil. Now, like it's the same kind of situation like Gopal. The Cushing choroidal develops due to the it is non-sutured cannula. It is came to the partially withdrawn stage. Tip of the cannula was in the air infusion cannula was in the suprachoroidal space, and fortunately my IOP was less than 40 millimeter mercury, so that it can cause what Dr. Hemant was telling, that presumed air venous embolism, because this may rupture the vortex vein. It can go to the pterygoid venous plexus to the internal jugular vein, ultimately to superior vena cava to right atrium, right ventricle, then pulmonary artery. So it can cause pulmonary embolism. So this is the situation. The cases are already reported. So fortunately, this kind of situation has not happened in my case. And what Sir was discussing about the entitled volume of CO2 and Dr. Gaurav, this is almost like same situation. We should think about the non-sutured cannula. It can go anywhere. It can be partially withdrawn stage. So do it carefully while doing the vitreous base excision. It cannot go. Should not go.
मेरे भी 2 वीडियोस बाकी हैं. What are you saying? 2 वीडियोस और बाकी हैं मेरे.
Maybe we can have people mute.
उससे क्या मतलब है? Discussion भी तो होता है.
I think maybe we can have somebody mute. I don't know who's but Pramod, any comments?
It is the Retina Live group, I think, who is handling that. From there, we are hearing that voice.
Oh, okay. So Pramod, any comments?
I think it's very well handled, very well managed this case. I think that's the best way, and we already discussed other points. I think no more comments.
Yes.
No, I think choroidals are a tough problem. And again, same thing with choroidals. Before people start doing something, always follow the infusion cannula. That's the first place to start, right? Know what you're doing and what is coming into the eye, because the nurses will say everything is working fine. but it's not. So always start with a cannula and then see what's happening. Anand, any comments?
Yeah, I think all good points made here. I think the important key factor here is the pressure gradient. Like Manish and Gaurav, you said it's also the play of the pressure inside the eye versus the pressure outside. Also, in this era of MIBS, when we are putting in non-sutured cannulae, the one big issue is the slippage, and that happens more when there's reuse of cannulae. Yes. And when you're infusing saline, it doesn't make so much a difference, because even if it goes the suprachoroidal space, that will again leak back into the intravitreal. There's not so much of it. It's when you move to air. I think one little thing for beginners is every time you move to air and using these MIBS systems, please look at that infusion cannula and see if it is inside, well inside and flush with the surface of the globe, so that you can prevent this kind of a situation. And management is great, as you've been shown. Yes, Dr. Hemant.
I think Hemant has a quick comment.
Can I make a comment?
Yes, please.
Yeah, maybe Hemant and Shobit then.
Yeah, generally the step that happens is when you do the depression for periphery, and
depression.
after
Yes.
you do the depression, once you take it off, generally one has to ensure that the cannula is in. So at that step, especially when you're doing in the inferotemporal quadrant, whenever you do depression, try to see that your cannula is again in, because that's the time when it occurs.
Yeah. Dr. Shobit?
Yeah. Another point for beginners, that when you, besides keeping a watch on the cannula, transfix it nicely with an adhesive tape, the infusion tubing, onto the drape. That really, and keep a laxity between the cannula, a loop, transfix it with a little play there, and nicely and leave it there. That
absolutely
goes a long way in avoiding slippage.
Yeah.
Yes.
Another thing is when you move the biome back and forth, sometimes it can hook it if it's too lax and it comes. That's
I'm not
another
using biome. Yes.
So another comment before I move on is also be very careful in watching the patient's blood pressure. Now, I know that anesthesiologists are supposed to do that, but if you look at your anesthesiologist and nurse anesthetist, I would say 95% of the time they're looking at their phone. So this happened to me last week. I said, maybe I need to text you that the blood pressure is 200 over, 140. You may want to check your phone, because you're not checking the machine. So I said, maybe we have to text these people now. I don't know, but I think that kind of taught them a lesson that anytime you get choroidals, look at the blood pressure. Okay.
I have two comments to make, sir. Can I make?
Yeah, quickly, because we're out of time.
One is he was using a valved cannula when this problem happened. And the number two is, if I am to make another infusion port, I would not use that same infratemporal quadrant. I may use another quadrant, maybe infranasal quadrant. Thank you.
Okay. Anand,
thank you. Yeah, let's move on, because we're kind of running short of time. Sai, can we have the slide show on?
This is a case where we had a dropped IOL, and when we started the case only, we noticed this subretinal hemorrhage. And this is the haptic which is stuck onto the oral area. You can see the infusion cannula and the haptic which is stuck there. And I had to remove that haptic which is stuck there. Actually, in fact, I cut that haptic and let one part of the haptic remain there. I went out and came inside, and this is what we are seeing: massive, almost kissing choroidal. Okay. Again, a case like this. So she was a 75-year-old lady, 77-year-old lady, and now it's difficult. Now again, I'm thinking of what is to be done right now. And then I made a small sclerotomy, a little posterior. This again could be blood, because there was subretinal hemorrhage to start with. It could be blood. So that is the area where there is a maximum height of the suprachoroidal. So I am making an opening there, cut open the conjunctiva, and made a small opening, increasing the pressure, and try to remove some blood. I made an opening, and then again using that same technique, where I went inside with the cannula. Now you can see that I went inside and actively sucking. Yeah, but the choroidal detachment wouldn't come. I'm trying to indent from the outside, seeing whether this is coming inside. But I'm not seeing the tip of the cannula here. I failed. I was not able to remove anything. I did not manipulate too much because this is massive choroidal detachment and there was no retinal detachment here. I closed. I closed. Less than 900. So it was a little difficult to go inside again. And over the next 2 months, she regained 6/9 vision with aphakia and the choroidal detachment completely vanished. So this patient we are now using contact lens to have 6/9 vision.
So I think
this patient also gave a history, cataract surgery which was done 10 years back. Now she brings her papers to say that there was a suprachoroidal which occurred during the cataract surgery which was done 10 years back, which we did not know while we were doing the surgery. Thank you.
Gopal, nice presentation. So Manish, I think this was the right time to end the dance. I think that Gopal, you did the right thing, and because the job was done. So any comments, Manish?
Well, I think it's the. I think all this tells us that we need to be very careful about our cannulas and the pressures that's going in, and the pressure in the eye and the valve cannulas. I think it's the whole interplay of these things which would partly avoid such a thing, and even if it occurs, I think we need to look at these factors and take care of it step by step.
Hemant, any comments?
Yeah, anything that causes choroidal hemorrhage like this, one thing is that you should just check, like what you mentioned about blood pressure. So just check for the blood pressure and whether the patient has any other history of any bleeding, or he's on anticoagulants or some of these blood thinners that can cause some of these problems.
And I think with choroidals in general, the less you do, the better it is. So unless it's affecting your case, I always tell the fellows, you know, when Google says you reach your destination, you reach your destination. Stop your car and get out of the car. That's it. Don't do anything more. Anand, we move on.
Yeah, absolutely. It's time for us to stop the car here right now on choroidals and move on to myopia-related complications.